Now, the next set of diseases in the oncology section, lung cancer, ovarian cancer, testicular cancer, and cervical cancer, lung, ovarian, testicular, and cervical, it's not that they're unimportant, it's just that the knowledge base for oncology, what is unique about it? I mean, oncology doesn't all start out with, well, we biopsy things to be able to see what the tissue is like. We biopsy things to be able to see what the histology is, because we biopsy things because we need to know, is the person going to get radiation therapy? Are they going to get chemotherapy? Are they going to get surgery? Are they going to get a combination of all of these things, or two of them, or one of them? What's the screening? That's preventive medicine, actually, but it's so important we're going to put it here twice. That's why. So these disorders, it's not that lung cancer is unimportant. Some people go to me, sometimes they say, hey, Conrad, why is your lung cancer section so small? And I go, well, you know, because it's just what you need to know. But for the most common cause of cancer death, how can you have a page or half a page? I go, well, I don't know. I'd like to get it down to one paragraph, honestly, because it's only what you absolutely need to know. So the first part is the screening for lung cancer are people who are people of the age of 55 to 80 years old who've had very significant 30-pack-year histories of smoking, and they should get a CT scan to be able to tell you whether or not they have lung cancer. There's a screening. This is new. There's never been screening for lung cancer before. There's never been screening before the last couple of years. It's colossally new. And the reason why this can be an easy section is that once you are biopsied for lung cancer, and you know you have lung cancer because sputum cytology is terrible, it's crappy, it's inaccurate, it's nonspecific. If it's negative, it doesn't exclude cancer. If it's positive, you still got to biopsy the lung. Sputum cytology is terrible. If it's negative, you still need to biopsy the lung. If it's positive, you still need to biopsy the lung. The reason why lung cancer is easy is because it really comes down to, can you do surgery to remove it, or do you have a person who's inoperable for their lung cancer? That's what it comes down to. So lung cancer is terrible and a horrible disease, but not unlimited for you. All lung cancer for you is like a tiny slice of nephrology, even less, because it comes down to this. You can't live if you have it attached to your heart. You can't live if you have it attached to your inferior vena cava or your aorta. You can't resect the vena cava. You can't resect the aorta. You can't resect people who have it bilaterally. You can't cut it out if you have bilaterally. You can't cut it out if you have a malignant pleural effusion or you have metastatic disease. You can't cut it out if it's attached to your esophagus. You can't cut it out if the lung cancer is attached to things inside your chest. You can't live without. But what you notice here is that it doesn't say the size of the lesion. It doesn't say the size. It doesn't say the histologic type. It happens to be that 90% of the time, things like small cell cancer happen to be bilateral. They happen to be metastatic outside the chest. They happen to have a malignant pleural effusion. They happen to be bilateral. They happen to be attached to the heart, the inferior vena cava, the aorta, bilateral effusions outside the chest. It's not so much that it's small cell cancer, it's the fact that it's spread out where you can't cut it out. Now, the size is not what drives it. It's better to have a 3-centimeter lesion attached to your ribs than a 1-centimeter lesion attached to your vena cava or your aorta. It's better to have a 4-centimeter lesion attached to your diaphragm. Take my diaphragm, cut it out. Than a 0.5 centimeter lesion with a malignant pleural effusion. It's not the size of the lesion, it's not the rib involvement, it's not the histologic type, except for the fact that small cell cancer is attached to other things or metastatic 90% of the time. It's not the histologic type, it's not the size of the lesion, and it's not rib or diaphragm involvement. It's whether or not it's attached to organs you can't live without, or bilateral, or things outside the chest. There is screening for lung cancer. That's new. Age 55 to 80, 30-pack year smoking, not quit within the last 15 years, do a low-dose CT scan and find that cancer. It's not great, but I would do it if I smoked that much. Okay. Now, ovarian cancer, what's different about ovarian cancer? Ovarian cancer, there is no screening. There is no screening. And when they say pelvic sonogram, abdominal sonogram, pelvic CT, abdominal CT, wrong, 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 wrong. When they say physical examination, bimanual, wrong. It just doesn't find ovarian cancer. Ovarian cancer is too small to be found by a screening physical exam, too small to be found by abdominal CT or sonogram. There is no such thing as a screening pelvic sonogram for cancer, not for cancer. Next, although it's associated with BRCA, we're not using this as a screening test. Ovarian cancer, you look for someone above the age of 50 who is having decreased weight, and yet despite the decreased weight is having an increased abdominal girth, and that's from ascites. Decreased weight but increased abdominal girth from ascites. Biopsy because it's malignancy. Now, what's different about ovarian cancer from the other forms of cancer? It's not the ovarian cancer, it's not the biopsy. It's not the fact that you do radiation and chemotherapy. Radiation and chemotherapy, good. It's the fact that surgical debulking. Surgical debulking, removing everything down to less than half a centimeter, actually makes a huge difference. Surgical debulking, removing everything that's above 1 centimeter, makes a huge difference. So surgical debulking surgery. What's different about ovarian cancer from the other things? Surgical removal of volume. There is no other cancer where we will tell you, chop that thing down so that all lesions are small. There is no other cancer in which we will tell you, remove everything that is above a half or 1 centimeter and physically remove burden of tumor, even if the tumor is metastatic. Nothing in the world is like this. Nothing in the world is like ovarian cancer where you're physically debulking the tumor. Oh, chemotherapy, we have lots of chemotherapy. Oh, radiation, we have lots of radiation. Oh, biopsy, this is cancer, we're doing biopsies. But surgical debulking, where you're physically removing as much mass of tissue as you can, that's unique to ovarian cancer. That's unique. Well, what's unique to testicular cancer? Oh, I have a mass and I need to biopsy that mass. I do surgery to remove the mass. I sometimes use radiation therapy or chemotherapy. Well, that sounds like all cancers. Biopsy a mass, surgical removal, chemotherapy, radiation. So what's different and unique? What is different and unique? When do you screen for testicular cancer? Who gets screening going around? Sometimes you feel like a nut, sometimes you don't. When do you go feeling around to go, never. There's no screening for testicular cancer. There's no routinely screening to squeeze testicles all day long to see if you feel it. The patient feels a mass. What's different and unique about testicular cancer is the type of biopsy Second, that you have tumor markers, the increased alpha fetoprotein, the increased beta HCG, the increased alpha fetoprotein, beta HCG, beta HCG, increased alpha fetoprotein, and increased beta HCG. That's unique for testicular cancer. You have these blood tests. The other thing, here's the two other unique things about testicular cancer. Because there's only a few cancers at screening: breast, cervix, colon, and lung, breast, cervix, colon, lung, breast, cervix, colon, lung. So lots of cancers have no screening that people do regularly. What's different about testicular cancer is not just that you have tumor markers that are meaningful, like alpha fetoprotein. It's the type of the biopsy. This is the biggie. This is the biggie. All cancers, biopsy. Take a piece of me. I need to see histology. I need to see pathology. But what's different is the type of the biopsy is not to cut the scrotum, and it's not to needle the scrotum. The type of biopsy: no needles of the testicle, no scrotal cutting, no scrotum cutting, no needles, no scrotum cutting. The type of biopsy is an excisional biopsy, where you pull the whole testicle out as one piece from the top. The type of biopsy is an excisional biopsy, to remove the whole testicle as one whole nut from the top. No needling through the scrotum, no cutting through the scrotum. Inguinal. Here's my inguinal biopsy sign. My pulling up from the top. My pulling up from the top. No needling the scrotum, no cutting the scrotum. You do the inguinal biopsy, cutting it up from the top, pulling it up from the top. That's the difference. So, never violate the scrotum. You don't needle the scrotum, you don't cut the scrotum, you pull it out inguinally from the top. It's like eating a walnut. If you had to eat a walnut, would you put a needle in the walnut? I don't think so. Would you cut the walnut? I don't think so. You crack the nut and take it out as one piece. That's it. So write this down. My testicles are like a walnut. Don't cut the nut. Don't needle the nut. Crack it open and put it out as one piece. There it is. My testicles are like a walnut. Last one is cervical cancer. And cervical cancer, we have screening from the age of 21 to 65. From the age of 30 to 65, you can go every 5 years with pap smear and HPV testing. It's every 5 years. Next is that cervical cancer. If you have a normal test, here it's every 3 years. If you have a normal test, it's every 5 years if you combine it with HPV testing. But if you have atypical squamous cells of undetermined significance, atypical squamous cells of undetermined significance, atypical squamous cells of undetermined significance, atypical squamous cells of undetermined significance. If there is HPV testing, we do colposcopy. Colposcopy is like putting a telescope in your vagina. It's looking with a microscope and a telescope up the vagina at the cervix and being able to take a very precise biopsy. If there's no human papillomavirus, then you repeat the test at 6 to 12 months. Next, if you have a person who's got more advanced disease, such as cervical intraepithelial neoplasia 1, 2, and 3, then we do colposcopic biopsy. Atypical squamous cells with HPV, colposcopy. Without HPV, repeat the test in a few months. Finally, the vaccine. The vaccine should be done for both boys and girls now, by the way. It's changed so that it's both men and women. And here's the other thing about the vaccine, because you should give it to every teenager. But the hard part is this. Why vaccinate against HPV? Not safe in pregnancy. Not safe in pregnancy. Why vaccinate even for non-virgins? Because one vaccine is good from age 9 to 26, the other one from age 11 to 26. Why vaccinate a non-virgin? Huh? They've already been exposed to human papillomavirus. Why vaccinate a non-virgin? Because what if they've only been exposed to a non-dangerous HPV? You're vaccinating to protect people against the dangerous human papillomavirus. But what if they've only been exposed to non-pathogenic HPV, the ones that don't cause cervical cancer? You're vaccinating people against HPV to be able to prevent them from getting the dangerous HPV, so even a non-virgin needs it. Cervical cancer screening, ages 21 to 65 without regard to sexual activity. Even if you're sexually active from 18 or 19, it's age 21 to 65. You go every 3 years. From the age of 30 to 65, if you combine it with HPV testing, it's every 5 years. If you have atypical squamous cells of undetermined significance and you have human papillomavirus, do a colposcopy. If you don't have human papillomavirus, you can repeat the pap smear at 6 or 12 months. Any more advanced disease needs colposcopic biopsy to see if it's more involved, because the management of cervical cancer is to remove that cervix and to radiate its cervix, so remove it and radiate it, remove and radiate. You give the vaccine to men and to women, to both boys and girls, and you vaccinate even non-virgins to prevent the pathogenic HPV. Oncology done already? Yeah. Because colon cancer is in the GI section, and hematologic malignancies is with the heme section, and lymphoma is with heme. That's right. I'll see you soon.